pneumonia is still probably the commonest cause of death worldwide. It's just the people who die of pneumonia have changed. It's different populations.
Hello and welcome to Hadassah On Call, New Frontiers in Medicine. I'm your host, Maayan Hoffman. Growing up, I remember my mother warning me, dry your hair or you'll catch pneumonia. It always sounded like this mysterious, frightening illness that could appear out of nowhere, and the stories didn't help either. We all heard of older adults who just caught a cold, and then suddenly it turned into pneumonia, and that was it. Even as a medical reporter, I'll admit I never fully understood what pneumonia really is, how it develops, or why it is considered so dangerous, even in the modern age. For something so common, especially during the winter, it's remarkable how misunderstood it remains. In this episode of Hadassah On Call, New Frontiers in Medicine, we're going to clear the air, literally, with Professor Neville Berkman, head of the Pulmonary Institute at Hadassah Medical Organization. We'll talk about what exactly pneumonia is, who's most at risk, and how it's treated, and the myths that persist about this lung infection that has been both feared and fatal throughout history. We'll also look at how new advances, from vaccines to AI-assisted diagnostics, are changing the way doctors treat and prevent pneumonia, and what we can all do to keep our lungs healthy, especially in the colder months. So grab a warm drink, breathe easy, and join me for this timely and important conversation. Welcome, Professor Berkman.
Happy to be here. Thank you.
So I want to get started with actually a very simple question. I'm hoping that you can define pneumonia, and how does that differ from other respiratory illnesses like the flu or bronchitis?
So pneumonia is infection of the lung. The lung is made up of the bronchi or the airways, which really is a kind of system of tubes that brings air into the lung. And the second component of the lung is the alveoli, which is the actual lung tissue where what's important happens, which is gas exchange. Oxygen goes into the blood and carbon dioxide comes out. Infection or inflammation in pneumonia is in the lung tissue itself rather than in the bronchi, which we would then call bronchitis. There are a lot of causes of pneumonia. A virus can cause pneumonia. So viral infection may cause bronchitis, it may cause sinusitis, it may cause pneumonia if it's infecting or causing inflammation in the lung tissue. So really, the definition of pneumonia is more where the infection and inflammation is rather than what the cause is.
Okay, so now why is it still considered so dangerous? Many fewer people are dying today of pneumonia than in the past, for sure. What's changed in terms of public health?
So I'm not sure that it's changed in a bad way. I think it's changed in terms of demographics and epidemiology. Pneumonia is still probably the commonest cause of death worldwide. It's just the people who die of pneumonia have changed. It's different populations. So whereas in the past pneumonia was very common in the average Joe, so to speak, it's now more common, much more common, I would say, in populations that are specific populations. So the elderly population, for example, who are at higher risk, people who are malnourished, people who've got other chronic illnesses, certainly immunosuppressive problems, cancers, treatment with chronic steroids, and people who've got other chronic illnesses like chronic lung disease, chronic heart disease, chronic kidney disease, diabetes, dementia. All of those things are predisposing factors for pneumonia. So it's not in people who are young and relatively healthy. It's not uncommon to have pneumonia as well, but the ramifications or the significance is different. So the large majority, if we take a total population of people who have pneumonia, they cope okay without coming to hospital. They'll get an antibiotic and sometimes they won't and they'll be fine.
So is it still considered then an older person's disease? Is that what you're saying? That those, if in terms of the risks?
So Yes, as well as the populations at risk, and also we're very concerned about pneumonia. I mean, it can be dangerous, of course, in children under 5 as well as in babies and children under 5. There's also a high risk group,
which is very reminiscent of the flu, where the younger and the older populations tend to be most at risk for severe flu, or also COVID, for example.
That's absolutely
interesting. So are you seeing any trends that are unique to Israel, whether regarding the climate or the unique populations that live here, maybe the lifestyle in Israel, that relate to who or how pneumonia is developed?
I would say not really. I think that trends in Israel are similar to Western countries.
Okay.
I think the general standard of living in the country is good. The health service is good. Another factor which is really important in terms of how frequent the disease is vaccinations. Influenza is a common cause of pneumonia, actually. So
you get the flu.
You get the flu, and the flu itself can be the cause of pneumonia, but flu often predisposes to a secondary bacterial infection, and that's probably the biggest danger of influenza or flu. So since there have been vaccines and effective vaccines for flu, and there are also vaccines for pneumonia, for pneumococcus, which is one of the bacterial causes of pneumonia. So those vaccines are widely available in Israel. So that's quite similar, I would say, to most of Europe and the States as well.
Who takes that pneumococcus vaccine, and when do you get it? As a child, or is that an adult vaccine?
So present recommendations are children below age 5, adults over age 65, and the populations that I previously mentioned who are at high risk.
Right. Now, when I grew up, my mom used to always say, don't go outside without a coat, or don't go out in the rain, or you're going to catch pneumonia. Is there any reality to that, or is that just sort of like a Bubby's myth?
Yeah, I mean, strangely enough, hundreds of years later, we still don't have a good answer to that, to be honest. It seems that cold weather does influence susceptibility to viral infections, and that also is due to various reasons. One of the reasons is that the ability of the airways, of the bronchi, to clear pathogens, for example, viruses, is not as effective when it's really cold. Another factor, which is probably the most important factor, is that in cold weather in the winter, people go out less, and so there's more crowding, and people are more in contact with other people who have infections, so that one passes from one to the other. So maybe going out the house is actually protected from that point of view. But we all know that if one goes out, certainly changes in weather and cold weather does often predispose to viral infections, to some inflammation of the bronchi, which then may be a lead in time to pneumonia.
What about other lifestyle factors, diet, exercise, maybe smoking or not smoking? Could these things impact pneumonia?
Yes, I didn't mention previously, I didn't mention smoking, but that's certainly a very important risk factor for pneumonia.
Really?
Yes, absolutely. So we see patients certainly who are chronic smokers have chronic inflammation of their bronchi, are at much higher risk for pneumonia. In terms of specific foods, no. In terms of overall nutrition status, certainly yes. People who eat less well, who are malnourished, are at higher risk. People who've got poor dental hygiene, for example, are also at higher risk. People who have problems with swallowing, of course. But as far as food is concerned, I would say it's the malnourished. Obesity may also be a factor. So people who are significantly overweight, that also may increase the risk for pneumonia.
Seems like every disease we always hear, diet and lifestyle. People need to just be healthy, eat right, and exercise. And most of the diseases can be kept away.
Absolutely true.
Yeah. So what about in terms of early warning signs that you might be on the verge of getting a pneumonia, or at the early stages of a pneumonia, so that you would say to yourself, maybe I should go and seek medical help right now and stop it before it gets farther?
So that's tricky because, as we know, common infections that we all get several times a year are usually of the nose and of the bronchi. So all of us, have a cough here and there. So it's often tricky to know when, that cough is part of a pneumonia. Certainly fever is a factor. So fever over 38 degrees in Celsius, that is a factor. If the cough is persistent, if there's a lot of sputum, certainly if there's chest pain, if the patient or the person is feeling generally unwell, they should be checked out.
What does the cough sound like with the pneumonia?
So that's very, very, very variable because pneumonia can be viral, as we said before, influenza, COVID or corona, which it actually causes pneumonia. So it's the cause is COVID, but the inflammation is in the lungs. So it is really a kind of pneumonia. Not in everybody, but most cases. And the people certainly who died when in the pandemic, the deaths were related to pneumonia or inflammation of the lung due to the COVID vaccine itself. So someone who's coughing a lot, not settling, those are the people that should be seen.
Now, let's say somebody does come here to Hadassah to get treatment. When they come in, how do you determine whether the pneumonia is bacterial, viral, or even fungal? And then how would that affect the kind of treatment that they receive?
So I think it's important for people to know that probably 90% of pneumonias do not come to the hospital. So community-acquired pneumonia is pneumonia in somebody who's obviously in the community, and the large majority people will get an antibiotic, or as I said before, may not, and it settles, and that's the end of the story. In about 10% of people, the pneumonia is more severe, usually in the high-risk populations, but not only. And it turns out that in the majority of pneumonias, we actually do not manage to identify a specific cause. So I would say out of the people who had come into hospital, who admitted to hospital with pneumonia, it's obviously the more severe patients. And these big studies have been done on that, only about 38% of pneumonias, we actually can identify the cause. And about 40% of those are viral. Around another 40% of those that we can identify are bacterial. The most common bacteria is the Streptococcus pneumonia, or what we call pneumococcus. That's the most common, but it's not. So the majority of patients, we do not actually identify the cause. And strange as it may seem, in 2025, we treat pneumonia empirically. In other words, we treat it based on clinical features with antibiotics that we think will most likely be effective without identifying the specific cause of infection. Now, things like as viruses and bacteria are common causes of pneumonia, fungi are very uncommon, certainly in healthy people. In people who have got immune issues or immune suppression, that's a different story.
With the antimicrobial resistance that's becoming much, much more of an issue, obviously, and supposed to be maybe even one of the largest challenges in the medical community in the next few decades, doesn't just giving antibiotics without identifying the cause potentially lead to more problems there?
We spend a lot of our time trying to rationalize and, if possible, reduce antibiotic use. When the clinical features are more suggestive of a viral infection, certainly in people who are relatively healthy, we may often decide or prefer to withhold antibiotics. When there is clear evidence for pneumonia, and I didn't mention this up until now, but an actual diagnosis of pneumonia requires an X-ray. So if you do a chest X-ray and see that there's what we call an infiltrate, that together with the appropriate clinical signs or symptoms like fever, cough, or a high white cell count, for example, that would be diagnostic of pneumonia. To be honest, in the community, often the general physician may put a stethoscope on the patient's chest, and if he has signs that are suggestive of pneumonia, then that is good enough. When we're fairly sure that it is pneumonia rather than just a bronchitis or viral infection, etc., then we would give antibiotics. And as I said before, we kind of go according to what we think is most likely to work. And in terms of antibiotic resistance, big issue. And I think doctors need to be very careful about overprescribing. And I think that there are a lot of countries, certainly in Europe and in the States, where there's a lot of overprescribing. When one gives antibiotics for pneumonia, the right thing to do is to give antibiotics that we would consider to be common garden variety antibiotics rather than more sophisticated or broader spectrum antibiotics. So the antibiotics that are good are antibiotics that have been around for 50 plus years. So simple amoxicillin, for example, or doxycycline, these are simple antibiotics that are effective in the large majority of people with pneumonia. So ideally, we would like to know what we're treating. The reality is that doesn't happen in the large majority of people. And in those cases, when it's justified to give an antibiotic, simple antibiotics are the right way to go.
Is there any trajectory of innovation or research that would help doctors to be able to identify the cause of the pneumonia, or is that something that we're not focused on?
No, so there's a lot of attempts to do that. And so again, it sounds a little absurd that in 2025 we're still treating empirically. But yes, there are a lot of attempts looking, for example, at there are ways of checking in the urine, checking in the blood, checking in the sputum to identify bacteria or to identify antibodies that would be suggestive of specific infections. The thing is, again, that the large majority of people with pneumonia, they come to their GP and they're treated without doing those tests. The problem really is the patients who are more severe. Those are the patients who would be admitted. So again, it's about 10% overall of patients with pneumonia will be admitted to hospital. Of those, some need intensive care. There's more severe patients would need intensive care. When the patients are admitted, a patient who's in intensive care who's got the most severe pneumonia, we do all those tests in order to try and identify the cause. But we would treat before, because you treat as soon as possible, certainly for a severe patient, because you cannot wait. There are molecular techniques to try and identify causes, but it's not something that's in common use at the moment. It's not something that's ready for use, for widespread use yet.
And I want to jump back to something you said at the beginning related to these severe patients. You said about 10% will check into the hospital, but you also said that pneumonia continues to be the number one killer worldwide. So how many people are dying of pneumonia every year? And I guess in Israel specifically, if you have that number.
So yes, I actually looked for that and didn't find it. Yeah. I know that the numbers in the States are around somewhere around 7 million cases per year, of which about 750,000 people are hospitalized. About 1.5 million go to the emergency room. About 750,000 are hospitalized. And the death from pneumonia depends on the age of the patient and the specific, whether it's community-acquired pneumonia where patients are healthy, the death rate is very low. It's less than 1%. In people who are admitted to hospital but not to intensive care, the percentage that would die of pneumonia is somewhere around 10%. People who are in intensive care, who are certainly on ventilators, the chances of dying are about 50%. So overall, it's still, because it's such a common disease, as the worldwide figures are somewhere around 400 million cases of pneumonia a year. Because it's such a common disease, it's still a very common cause of death. What often happens is that people who have other illnesses, for example, someone who's got cancer or someone who's got severe kidney disease or diabetes, that they will die because they develop a pneumonia towards the end of their life. So the pneumonia is what actually is the cause of death, even though, of course, the predisposing diseases would maybe be an important factor. So, we all know the adage that pneumonia is the old man's best friend, because frequently that is what actually causes patients to die at the end of the day.
The end of their lives. And in terms of, we always talk about heart healthy, how to keep our brains active. What about lung healthy? Are there certain things that we can be doing to ensure that we just have healthier lungs day to day beyond the diet and exercise that we talked about?
Well, no smoking, do the exercise, do the right diet, get the vaccines if you're in the right groups. Influenza vaccine is really important for everybody. Pneumococcal vaccine is important for the risk groups that we spoke about. There is more and more use of other vaccines as well. The RSV vaccine, a respiratory syncytial virus vaccine, which is also in high risk populations, is important and can reduce the risks of lung infections. So that simple things, and they make the difference.
Now, I know that you also lead the multidisciplinary post-COVID clinic here at Hadassah, and I'm curious if you've seen any link between the COVID-19 and pneumonia, or any lasting repercussions or complications that have happened as a result of COVID to people.
So we're all haven't quite got over the scars of the COVID pandemic, and it's still with us. We're still seeing upsurges of COVID, but it seems to be a different disease. It behaves very differently in 2025, but it does cause infections of the lungs. Mm. So the most common manifestation is still cough, respiratory infections. Pneumonia per se is not. We are not seeing a lot of pneumonia now with the newer COVID episodes. It's people who have immune deficiency, those are the people who we're most concerned about. It is very important to check for COVID in people who have, even in 2025, who have cough, who have symptoms that might be suggestive of pneumonia, to check for influenza and check for COVID, because those are things that we can actually treat. So they two viruses for which we actually have treatment options.
Right.
In terms of people who had COVID, a very small number who survived. Of course, those who didn't survive obviously had severe lung injury, but of those who survived, a very small number have got significant lung injury, and they would then be predisposed to pneumonias in a similar way to somebody who has chronic smoking lung disease or other chronic lung disease. But it's not that common, to be honest, chronic a lung injury from COVID.
Because most of the people, I guess, who had that and ended up on those respirators didn't make it through the COVID.
That's right.
Right. No, that makes sense. Now, looking ahead, we talked about some of the new ways for treatment, but are there for diagnosis, but what about in terms of treatments? Beyond the vaccines, are there new treatments that are coming down the pike that we should know about?
So, I think the whole world is at a point of crisis in terms of bacterial resistance, as you mentioned previously. So I think one of the things that's we need to stress, and I mentioned before, is don't give antibiotics unless you need to.
Right.
Try and give as narrow spectrum as possible to cover the most likely causes of the infection. There is a trend now to give antibiotics for shorter time. In the past, we treated pneumonia for usually 10 days, 7 days. There's now a strong trend to reduce the time of antibiotics up to even sometimes 3 days. So those things will reduce exposure. There is a lot of talk and a lot of hype about other ways of altering what we call the microbiome. In other words, maybe giving other bacteria, which are friendly bacteria, to try and stabilize or overcome the pathogenic bacteria. Again, there is a lot going on with that. Nothing that's close even to use at this present time.
Now, I remember growing up that if you would take not all of the antibiotic dose, like they would give you 10 days and you would take 3, they would say that actually built resistance. So now we're moving to short-term, actually the opposite recommendation?
Yes. And that's based on good studies. There are now good studies to show that shorter is better. For pneumonia. Again, it has to be a case-by-case basis. But if a patient, for example, is admitted to hospital and within a day there's fevers come down and there's signs of inflammation are coming down, you can probably stop the antibiotic 2 days or even 1 day after that, and they're okay. Patients who are of high risk, who've got a lot of comorbidities, would obviously be more careful. People who've got immune deficiency, that's a different story, of course.
Right, of course. Now, I just want to end by asking you about your work here at Hadassah. You have the privilege of serving in this role here at the hospital, and I'm wondering if there's anything unique or special about doing your role here at the Hadassah, or even in Jerusalem in general.
So yeah, I came to Israel 40 years ago, and I've been in pulmonary here for the last 35 years or so. And yeah, I think it's a special experience. We see patients from both the Jewish and Arab populations, and to feel, of course, a strong identity with the people that we see and who we treat, and we feel like we're at home. I think that Hadassah allows this unique combination of excellent academic medicine together with research, together with teaching. We're very closely knit, as you well know, with the medical school. And that's, I think, there's nowhere else in Israel that gives that. And I think there are not a lot of other places worldwide that have that combination.
And Professor Berkman, is there anything else that you want to add, or you feel that our viewers and listeners should know that we didn't get to talk about?
No, I think that just to emphasize the points that we said before, healthy lifestyle, get your vaccines, don't smoke, and don't take antibiotics if not needed. But obviously the flip side to that is don't wait until you're too sick if you need them.
100%. Well, Professor Berkman, thank you so much for the insights today.
Thank you.